So, Mehmet, can you hear me clearly?
Yes, yes.
Okay.
How are you doing?
It's fine. It's fine. They told me it's 1 p.m., but it's 2 p.m. here.
Oh, yeah.
I joined an hour early.
In fact, this is my mistake because I arranged everything with Turkish time, and the summer time zone we don't accept because of that. We didn't change.
All right, right.
It is
right.
now 4 o'clock in Turkey.
Yeah.
But you
All
changed.
right.
Sorry for that.
No, that's good then. Yeah, as I said, if there might be an issue with the internet, hopefully not. Hopefully we'll be able to hear each other.
Yeah. Yeah, live meetings will be much appreciated.
Yeah.
I hope we can start it.
Correct, yeah. Are you coming to Islamabad next month?
No, me not.
Karachi? No,
What is the
not.
meeting there?
Oh, in Karachi, the WFNS meeting. No, that's fine.
But I will go to Karachi.
You're going to
In
Karachi,
May.
yeah? In May, right.
Yeah.
So I might see you there then. I might. Sandeep, how are you?
Good. Life is very busy these days. So
All right.
Like
So
always.
you're clearing the backlog.
yes, patients are coming back with a vengeance. So all the hospitals are full right now.
Gosh.
And health family, Sandeep.
Everybody is good. Just still work from home is still continuing. So offices are still not open mostly. So, but as far as COVID is concerned, it had almost gone from all over the country, but there's a sort of new wave coming from our region only, Delhi and around. So the numbers, most of the numbers are from Delhi region only right now. So
Okay.
so the restrictions are coming back in gradually.
Gosh, it's not going to go away.
Yeah, so the mask mandate was removed just 10 days ago, but now it was back to 2 days ago, it was back. So
Right. So it's 2 o'clock. Should we start then?
I think a minute left, I think.
Yep.
I think we have one more minute.
Okay.
I think it's time now. So
Yeah. Dear friends, dear members of the World Spinal Column Society, this is another operating theater, World Spinal Column Society certificate course. The topic is back pain and lumbar disc herniation, which is very common in our practice, but we have still problems in diagnosing and treating that. So then many alternative techniques are offered. So then many surgeons are confused with the diagnostic techniques and then management options. The first section will be on the back pain and disc herniation. What is the relation? And we will moderate the session with Dr. Paula Pereira. I ask Paulo Pereira to start it.
Thank you very much. Welcome to this session. And the first speaker is Professor Amjad Shah from UK, from Coventry, who's going to talk about epidemiology and etiology of back pain. Please, Amjad.
Thank you, Paulo. So I've been asked to talk on epidemiology of low back pain and causes of back pain. So low back pain is a heterogeneous and inconsistent diagnosis. It is therefore important to define it anatomically. So WHO definition of
Can you
back...
make it whole page? Whole page.
make it
Oh,
on the
yeah.
slideshow.
Yeah, I'll make it. Yeah.
Thank you.
Good.
So, as I said, the back pain is a heterogeneous and inconsistent diagnosis. It is therefore important to define it anatomically, and WHO definition of back pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage. And the low back pain is defined as a pain or stiffness, both pain or stiffness, localized below the costal margin and above the inferior gluteal fold. So that's the definition. And in terms of classification, we have a pathological classification or on the chronicity of the pain. So we have pathologically, we can classify the back pain into mechanical, inflammatory, myofascial pain or referred pain. And in chronicity, if acute, subacute, and chronic pain, if anything is more than 3 months, we call it chronic pain. Less than 6 weeks is acute pain. So why is back pain a problem? It's extremely prominent healthcare issue and one of the most common reasons to seek medical attention. According to literature, it's between second or fifth most common reason for seeing all the physician visit, most common reason for visit to neurosurgeons, and up to 80% will experience an episode of back pain at some point, and healthcare cost in UK in 2000 was about 12.3 billion. And the cost of low back can be direct due to the loss of due to the cost of the medical care, and indirect cost due to loss of the time and the work and disability payments. So I think it's got extremely high cost problem, and it's a big issue for the people concerned who deal with it. So in UK, 80% of the workers have a back pain, they've reported, and it's the most common cause of taking the sick leave after the flu in UK. And the most common cause of the days lost in the work due to the back pain compared with any other medical condition. In terms of epidemiology, so I'll quote the Mattuzzi et al. Paper of 2020, the back pain, as I said, is a significant worldwide burden. Incidence is about 245.9 million, so about 246 million cases per year, and prevalence is 577 million cases at any time, and there is 64.9 million disability adjusted life years due to the back pain. So that's extreme burden onto the NHS and onto society and on the medical facility. And the worldwide epidemiology of low back pain, the Musi et al. Performed systemic review of 28 studies of low back pain epidemiology and identified the following factors associated with increased prevalence: the increasing age, lower socioeconomic status, female gender, education, and smoking. However, the other people have contested this rather than low socioeconomic status. In fact, the country who are well developed, the incidence of back pain is higher. So this is a bit still controversial whether the low socioeconomic status, which leads to the higher incidence of back pain, or is the education. And in terms of the back pain and gender, women tend to suffer more with back pain than men, and both a higher prevalence, a relatively higher impact on equality of life reflected to daily, as I said, the disability adjusted life years. Why? Because exposure to greater MSK loads, pregnancy, childcare, and biological difference, higher rates of osteoporosis, and less muscle and bone mass. And in terms of back pain and the age, there is evidence from the literature that as we grow older, initially the cases of low back pain exhibit a gradual increase with the age after the birth, with incidence peaking at 40 to 50 years and then progressively declining. Previous studies tend to show that back pain affects people of working age more than the other ages, primarily because of hypotheses relating back pain to work-related physical factors. And back pain in children, the clinically perceived to be uncommon but potentially understudied. As many as 1 in 20 children may suffer from low back pain at any given time, and prevalence in childhood increases with age. Psychological and psychosocial factors play important role. The other studies have shown that in children, the 3 most important factors which plays anthropometry, that is the ratio of height, weight, and ratio of the upper torso and with legs, growth spurs, and lifestyle factors and psychological factors, they all contribute into the childhood back pain. Back pain in the older population, why the prevalence of back pain tends to be plateau from the 7th decade of life onwards is probably due to reduced exposure to the occupational and everyday activities that compared to the people who remain active between 60 and 70. And Dawkins et al. Proposed that their prospective cohort study that back pain in more than 75 years is 23% prevalence of non-disability low back pain. So these are some boring statistics, but the main message is that it starts plateauing from the age of 50 to 60 due to different reasons as we grow older. Now, the predictors of low back pain onset in older age is poor health, previous back pain or back surgery, depression, and social isolation, and loneliness, and not leaving house can all contribute to the back pain in the older population as compared to the childhood, which were completely different factors which result in the prevalence of the back pain. And prediction for the future is the Epidemiology et al. Again demonstrated nearly linear increase over the time in burden of the low back pain. And numerous reasons for this is increasing population, aging population, lifestyle changes, obesity, and at the same time, healthcare providers are increasingly stretched because of the effects of COVID pandemic. So their predictions are that the incidence will increase rather than decrease because of the mechanization and the lifestyle we are living in. So it might more burden of the low back pain to deal with. Relevance to the clinician is then, if the problem is increasing, is understanding, improving the investigation, for example, measurable biomarkers, improving public awareness, and study socioeconomic consequences, and then treating accordingly to, and some extent, to come up with a preventive measure to reduce the burden overall. So going back, the back pain is the second cause of medical consultation in the world, second to the flu. And this is the study we did here in the UK. At any time, this is about, again, 7 to 8 year old, the population of out of the 60 million, there's 16.5 million at any time, the prevalence, and they about 3 to 7 million, they contact the GP per year. And in outpatients, there are 1.6 million appointments a year just for the back pain. And about 100,000 people are admitted per year due to back pain. And about 24,000 surgeries are carried out. And this number has increased since then. Pai et al. Found in 2004 that in the US, low back pain was the second leading symptomatic cause for physician visit, as I just said before. Third commonest cause for surgical procedures, and fifth commonest reason for hospitalization, and first common cause visit to the orthopedic surgeon or to the neurosurgeon. So, as I said, it is a big burden to the resources because of the back pain. So back pain is the most common reason for the worker compensation claim. So how big is the problem? Is the back pain a problem? As I said, it's a big problem and is the most common reason for the worker compensation, most common reason to go off work, and the second common reason for the consultation, and third common cause for the disability. And so this is the more or less about the incidence and the epidemiology of the back pain. And my second bit of the talk is, again, I have to squeeze it in next 4 or 5 minutes, is causes of back pain. So I call and I teach, there are 6 M's I tell to the students: mechanical back pain, myofascial back pain, metabolic causes, medically urgent causes of back pain, then medical causes like spondyloarthropathies and inflammatory condition, and then masqueraders of the back pain, which is very, very important. I'll quickly show a few slides about that. So, as we all know, the common cause of back pains are sprains and strains and degenerative changes in the muscles and discs and connective tissues of the back, usually self-limiting. Acute musculoskeletal back pain usually improves after 2 to 5 days and resolves in less than 1 month. Chronic back pain, the symptom lasts more than 3 months, 6 months. So we need to be aware of the seronegative spondyloarthropathies, all of which can give the back pain, which include ankylosing spondylitis, reactive arthritis, and enteropathic arthropathy. So I think people can read it separately, but this is a known entity. And we need to be aware that this is common between the age of 20 and 40 and may sometimes be relatively mild, and many patients do not seek medical advice. Inflammatory back pain or lumbar dorsal pain at night or stiffness in the morning, that's the hallmark of the pain, usually improves on walking and gets worse with inactivity. And then you get bilateral buttock pain, which can alternate between the 2 buttocks, and peripheral arthritis, mainly asymmetrical. These are the features of, and then enthesitis, pain around the Achilles tendon. The metabolic cause, which normally we ignore, is the osteoporosis, the quite common cause of diffuse back pain, then Paget's disease, osteogenesis imperfecta, Gaucher's disease, vitamin D deficiency, which is very common in UK, and hypophosphatemic adrenal dystrophy. They all can give the back pain. Then medically urgent causes of back pain we need to be aware of from the history. If there are atypical features or tumors of the spine, primary or metastatic, infection, and fractures. It's very important when we're taking the history of the atypical features and there any suspicion, we need to be aware of these causes of the back pain. Non-degenerative spinal causes of back pain, as I said, the infection, tumor, metabolic bone disease, and be concerned when pain is severe, refractory, atypical in location or character, and with particular features of either infection or malignancy or metabolic conditions. It's all in the history. When the back pain is not just back pain, masqueraders of back pain, that's my favorite topic. So we need to be aware that back pain does not always been coming from the structure of the spine. And I have seen every masquerade of back pain in my career over the last 25 years. I quickly show you the scan of this. Is one of my consultant colleagues who used to work with us and in a gynecology department. She was going in and out to see the people for the back pain, which was worse during nighttime. It was constant pain. And this was the scan report saying that the minor spondylotic changes. Eventually, she came into the clinic to see us. And when we went back to the CT scan, you can see there's a loss of definition in the presacral region. Unfortunately, she had a colorectal carcinoma, and she didn't survive and she died. By the time it was picked, the tumor has spread all over her body. This is another patient which was referred to me with severe back pain. You can see the superior end plate compression fracture. But when I spoke to the patient said her pain increases during nighttime and it's worse nighttime, she can't sleep. So I would have expected the pain will be worse on lying, better on lying down with the osteoporotic fractures. Again, this was the report. But when you go back to the scan, there's a large tumor sitting here, which was missed initially. And again, unfortunately, she died due to the spread of the tumor. She had ovarian cancer. So the whole thing is in the history, not in the scan. Scans are for us to help. We have to correlate the history with the examination. This was another patient who was referred to us as a cardiac whiner with severe back pain and bladder incontinence. So unfortunately, it had a, you can see the air under the diaphragm on both sides, has a ruptured duodenal ulcer. Yes, patient had a back pain. Yes, patient had an overflow incontinence. Patient wasn't incontinence, wasn't cardiac whiner. There was small bulging disc on the scan. And when we examined the patient, had a typical board rigidity, and the patient problem was due to the ruptured duodenal ulcer. This is another patient you can see here, had an aortic dissection, again presented to us with severe back pain and bilateral leg pain, and some sensory symptoms. And the scan was equivocal, and when we examined the patient, you can see the patient had a pulsating aorta in the abdomen. So it's very important to remember this picture, that back pain is not always just a back pain. So a myocardial ischemia can give you the pain as seen in the blue. The cardiac ischemia atypical can give you the central pain. Pyelonephritis and renal stones can give you pain typical, mimicking with the pain of the thoracic disc. And same, the cholecystitic and peptic ulcer and pancreatitis can do the same. And if you see the bottommost, the blue area here, you will see a lot of patients complaining of the pain around the sacroiliac joint area. As I said, you need to exclude the inflammatory spondyloarthropathy, pelvic inflammatory disease, ectopic pregnancy, fibroids, endometriosis, and prostatitis. All these can give you the back pain. And I'm sure all of us would have seen these causes of patient presenting. It's all thinking about it, that back pain is not always coming from the back pain. So I think I've got my 15 minutes.
Yeah, yes. You can, if you come to conclusion.
I tried to put everything together for 15 minutes.
Yeah.
So I think there is
Thank you very much,
lot.
And we will have more time in the discussion after the three presentations.
Yeah.
Thank you very much, and then I pass to
because I'm doing the clinic also parallel to it. I'm doing the clinic, so I'll try to keep on. Thank you.
Okay.
Thanks.
So, Mehmet, can you please introduce Professor Yeşim?
Yes. I'm very happy to introduce you, Professor Yeşim Kirazlı. She's one of the good friends from physical therapy unit. She's professor of physical therapy and rehabilitation, and she will tell us one of the most controversial subjects: how can we prevent the back pain? What are the most efficient techniques to prevent it? Yes, Yeşim.
Okay, thank you. Okay, thank you so much, dear chairpersons and dear colleagues. As you know, the global point prevalence of pain is 12%, and with the aging population, the number of people affected is likely to increase over the coming years. A key contributor to the burden is the high recurrence rate, and approximately 1/2 of the patients experience low back pain within 1 year after recovering from a previous episode. It is very important to know whether it is possible to prevent low back pain, and if so, which interventions are most effective. There are some major limitations, although there are some systematic reviews. because some of them are out of date and they report data from randomized clinical trials which include patients of symptomatic participants, which means it is not a primary prevention study, and they do not consider the strength of evidence and etc. Therefore, it's very important to have a comprehensive high-quality review, which includes the most recent publications and which provides a current overview of the effectiveness of prevention strategies. This review is very important because it is the first to have included a variety of low back pain prevention strategies and conducted a meta-analysis of randomized controlled trials. And it included patients who did not have back pain before. Therefore, it's a primary prevention study. Exercise in combination with education is likely to reduce the risk of low back pain. There was a 45% risk reduction. Exercise alone also may reduce the risk of an episode of low back pain and sick leave, at least for the short term. The available evidence suggests that education alone, back belts, shoe insoles, and ergonomics do not prevent low back pain. And the exercises which were evaluated through this review and meta-analysis were all different kinds of exercises, which means strengthening, stretching, and combination exercises, core exercises, all different kinds of exercises, not a special type. And in this review, also, it included trials with only primary prevention. And it was shown that the combination of strengthening and stretching or combination of strengthening plus aerobic exercise, which was performed 2 to 3 times a week, would decrease the occurrence and severity of low back pain by 30%. Unfortunately, education such as being provided in back schools appeared to have no additional beneficial effect. And this new meta-analysis suggests that exercises can reasonably be recommended for the prevention of low back pain in the general population. And in this review, it was made with the aim taking into consideration to date, no one particular exercise has been shown to be superior to the other. Therefore, the researchers wanted to compare the efficiency between 2 types of exercises: the individualized graded lumbar stabilization exercise and walking exercise through a randomized controlled trial. And the result was lumbar stabilization exercise and walking exercise should be recommended to patients because they help not only to relieve back pain, but also to prevent chronic pain through the improvement of muscle endurance. For the lumbar stabilization exercise, it was customized for every individual and made during different positions of the body, and it was a graded one. But walking exercise was simple and it was found as efficient as the core stabilization. Walking is relatively easy to comply with and is highly cost effective. So it comes into mind, why should we get involved in such complex exercise regimens if walking alone is equally effective? This study includes more than 40,000 people. They were evaluated with questionnaire, and it was seen that regular walking with a longer duration for more than 3 days a week, which means 90 minutes a week, is significantly associated with a lower risk of low back pain in the general population aged over 50 years. And the risk of pain decreased with increasing walking days and duration. Yoga is a light exercise, and this review is important because it includes a total of 18 randomized controlled trials. And it was seen that yoga might decrease pain from short term to intermediate term, up to 7 months, and improve functional disability status from short term to long term compared with non-exercise. And yoga had the same effect on pain and disability as any other exercise or physical therapy. Pilots is another method which is very popular, as you know, and the consensus in this field suggests that Pilot's method is more effective than no exercise intervention in the short-term period. Further studies should be carried out in order to better understand the short-term and long-term effects of Pilot's programs on low back pain reduction. There are some proven risk factors for low back pain, so it is logical to think that elimination of these risk factors could be helpful to eliminate the first attack of low back pain. Up to this study, there has been no previous attempt to summarize the evidence from existing systematic reviews of risk factors for low back pain. In this review, it's an umbrella review, 15 systematic reviews containing 134 cohort studies were included. And it was seen that characteristics of the individual, such as age, poor general health, such as smoking and obesity, and physical stress, such as whole body vibration related to occupation, and psychological stress, such as depression, are risk factors for low back pain. And this systematic review includes not only adults but also children, so it's important. Among adults, sedentary lifestyle, prolonged sitting time and driving time, excess weight and smoking were the significant risk factors. Among children, sedentary lifestyle was a remarkable risk factor for back pain, including prolonged TV watching and computer, mobile using, and console playing time. We know that if you have a sedentary lifestyle, which means prolonged sitting, lower back muscle strength decreases, intradiscal pressure increases, lumbar spine stiffness decreases. And there are also adverse psychological health related to sedentary lifestyle. But if a person works in an office and sits 8 hours a day, for example, but after work he goes and after too much sitting gets engaged in moderate intensity physical activity, we don't know the results. You know, physical activity in this way strengthens the back muscles and can contract the negative impact of sedentary behavior on psychological health. But we don't know the results for that. If it decreases or eliminates low back pain. It's a nationwide cross-sectional study about weight change, and weight change was defined as a difference in weight from 1 year prior year. On multiple regression analysis, weight gain was significantly associated with back pain compared with no weight change. Especially weight gain of more than 6 kilograms was particularly closely associated with back pain. Weight gain is significantly associated with chronic low back pain, and in particular, the greater the amount of weight gain, the stronger the association with an increased risk of chronic low back pain. But unfortunately, there was no association was found between low back pain and weight loss. And randomized controlled trials show that weight loss interventions may provide moderate improvements in pain and small improvements in disability. But it is said that there is limited and inconclusive evidence for weight loss interventions targeting spinal pain. And this study is important in showing intervertebral disc changes after reduction in body weight with bariatric surgery in morbidly obese patients. And this surgery showed that intervertebral disc height changes were significant after weight reduction. The lumbar 4 and lumbar 5 disc space height increased almost 2 millimeters 1 year post-surgery. And therefore, there was a clinical significant improvement in axial back and radicular leg pain after this bariatric surgery. There are few high-quality randomized controlled trials that investigate the effects of targeting lifestyle risk factors in people with low back pain. And with the aim to determine the effectiveness of a healthy lifestyle program for low back pain, targeting weight, physical activity, diet, and smoking to reduce disability in patients with back pain, was started this trial, but we don't know the outcomes, so we are looking forward to see the outcomes. As a conclusion, exercise alone or in combination with education reduce the risk of low back pain. But it is still not clear exactly which factors or particular kind of exercises may be responsible of such improvements. We don't know if any kind of exercise is superior to another. Walking at least 3 days a week, which means 90 minutes a week, has been shown to prevent low back pain. Yoga and pilates have the same effect on pain and disability as any other exercise in chronic low back pain, but these are not prevention studies primarily. Poor general health, such as smoking and obesity, physical and psychological stress, such as depression, and characteristics of the person, such as age, increase risk for a future episode of low back pain. Longer duration of sitting time is a risk factor. Furthermore, long duration of sitting time with low physical activity further increases the risk of low back pain. Sedentary behavior, whether in work or leisure time, associates with a moderate increase in the risk of low back pain in adults, children, and adolescents. Healthy lifestyle program targeting weight, physical activity, diet, and smoking is very important. Thank you very much.
Thank you. Thank you very, very much for your very comprehensive overview and particularly for the take-home messages that were very clear. Thank you. Thank you very much. And
thank you very much.
We look forward to having you in the discussion just after Professor Salman Sharif's presentation.
Sure.
Thank you. So now I have my pleasure to introduce Professor Sharif, who's the president of the World Spinal Column Society, and he's going to talk about acute back pain. Please, Salman.
Thank you, Paolo. Can you hear me okay?
Good.
All right, brilliant. Just to say that the session following this, instead of me, Nicola is going to moderate. I'll just hang around and enjoy. Right. So thank you again.
That's risky behavior, Salman.
Listen, guys, it's again pleasure to see you all here, all the friends who've joined again. And I must thank Mehmet, Joachim, and Kim, who have done an amazing job in getting amazing lineup for this session. So we're going to be talking about acute back pain, relations of history, examination, radiology. Obviously, as neurosurgeons, we rarely do that. We look at scans and we say thank you, and we move on. Well, we put these words in there and did a literature search and found 7,837 studies with 1261 review articles, 168 meta-analysis, and 766 clinical trials. So, we start with some of them. This systemic review published in 2020, and they said what we already know. One of the most common complaint is back pain. And there are 3 categories: acute, as we know, less than 4 weeks; subacute for 4 weeks to 3 months; and chronic from then onwards. What can the history and physical examination tell us about back pain? There are key questions you need to ask. Is there a serious systemic disease causing the pain? Is there a neurological compromise that might require surgical evaluation? So basically, a focused and well-performed history and examination can help triage whether further imaging or diagnosis is needed. So that's been there for like 30 years. It hasn't changed in any way, and it's still there. So there are red flags in history and red flags in examination. So history of cancer, steroids, osteoporosis, abnormal neurology, new falls, ataxia, more than 3 weeks of midline pain, nocturnal pain, sphincter problems, bilateral leg symptoms, anticoagulant use, IV drug use, fever, immunocompromised, unexplained weight loss, recent spinal anesthesia, failure to improve after 1 month, age more than 70. So all these risk factors could be there. If you have back pain along with that, then you need to be concerned. On physical examination, obviously fever, motor weakness, sensory problems, subtle anesthesia, diminished reflexes, positive Babinski, fecal incontinence, and urine problems. Yellow flags, certain psychosocial factors, depression, passive coping strategies, if person is not satisfied with their job, higher disability levels, disputed compensation claims, and somatization. And we know that, and we see this in our clinic all the time. So focused clinical examination would be inspection of the back with attention to the area of discomfort, direct palpation of the spine and paraspinal muscles, and to assess the range of movement, inflection, and extension. And is that causing any impact on daily activities and time to recovery? Well, this is a very busy slide, but basically it gives you a flow chart, how to go about things. So if you've got a progressive neurological deficit with back pain, and yes, if there are risk factors along with that, then you go for an MRI with or without contrast, depending on what you're thinking. If it's not, there's no consent for cauda equina syndrome, and there's then you don't have to do much. You need to follow those patients. On the other hand, if there is contraindication for MRI with a suggestion of cauda equina, then you can either get a CT myelogram. If not, then you get an MRI with or without contrast. If there is no contraindication, if there is contraindication to MRI, you get CT. On the other hand, if you have prior lumbar surgery history, if it's not there, then if it's trauma, osteoporosis, elderly, then, if none of these, then you get 4 to 6 weeks. And if it doesn't settle, then you can think about if there are flags available, then you can get a scan or not. If it's a chronic problem, going on to subacute problem, then obviously you need to see would these people get better with medicine and physical therapy. If it becomes chronic, then you can try it depending on how the patient is and there are other factors involved or not. Then depending on MRI, you can decide what you're going to do with that patient. So classification based on clinical presentation, again, a recent study. So signs, symptoms of radiculopathy, pain radiating down lower extremity, motor weakness, dermal sensory loss, reflex changes, mental factors may influence symmetry, positive nerve root tension, including Lasig, tenderness over the sciatic notch. So what about the reliability of SLR that we do all the time, and can it tell us anything? It can differentiate sciatic pain from pain due to hip pathology. With patient supine, we do this all the time. We raise the affected leg by the ankle until pain is elicited, usually between 30 to 70 degrees. Positive tests consist of leg pain or paresthesia, then distribution of pain. Back pain alone does not qualify. The patient may also extend the hip to reduce the angle. So this is SLR given here. And this basically would elicit the difference between hip and sciatica. So recommendations from that study were that they got 15 studies included in this meta-analysis. 119 patients had back-related leg pain. 439 were included in supplemental analysis. Meta-analysis showed that at least fair inter-rater reliability when a positive SLR required provocation of lower extremity symptoms or pain. So basically what they were saying that it is reasonable to predict that this patient would have a disc problem. SLR reliability was least moderate when tests including structural difference, like we added ankle dorsiflexion into it, So it was not as good. So XSLR was not as reliable according to this study. Low prevalence of cross-SLR tests led to wide-ranging reliability estimates. Confidence in the evidence for identifying a positive SLR or cross-SLR was moderate to very low in this study. Literature, again, poor quality. The majority are case series, restricted in diagnosis accuracy of neurological examination in detecting disc herniation with radiculopathy. High sensitivity, it could be useful to rule out lumbar disc protrusion. Utility is limited due to low specificity that can be positive in also ischial tuberosity pain secondary to other causes as well. So you have to be careful and able to differentiate between the two. How SLR and cross SLR influence patient-reported outcome measures in patients with a lumbar disc herniation. So they had 216 patients divided into 40 female and 60 males, and 102 negative SLRs. 42 had positive SLR, 94 had positive SLR, whereas 20 had both. So positive SLR had worse patient-related outcome measures, with a positive XSLR sign associated with worst scores. So patient-related outcome measures scores indicating a lower health-related quality of life, increased level of disability, pain, anxiety, depression, and greater expectations are associated with positive SLR and XSLR test. So we know that from this, that obviously with SLR can differentiate, but again, the studies out there are not as effective. Contralateral SLR, crossed SLR, expect no augmentation with rotation or dorsiflexion. So, you can do that and find out. Femoral stretch test, you also known as reverse straight leg raising, patient prone. Patient's examiner's palm at the popliteal fossa, knees maximally dorsiflexed, often positive with L2, 3, and 4 nerve root compression. And SLR is frequently negative because of L5S1. Bowstring test, once pain occurs with SLR, lower the foot to the bed by flexing the knee, keeping the hip flexed. Sciatic pain ceases with this maneuver, but the hip pain will persist. Sitting knee extension test with pain seated and both hip and knee flex 90 degrees, slowly extend one knee. Stretches nerve root as much as the moderate degree of SLR at the same time. So other signs, Faber, we know, can differentiate with the hip movements, and it's important to do that in every patient because about 10% of these patients could have bursitis, sacroiliitis, or some kind of pain in that region, and that you can differentiate from a disc problem. Radiology, there are high false positives. So if somebody's asymptomatic and you do MRs, it's been shown that many of them may have a disc prolapse or disc bulge, or some kind of pathology in their MRI. Degenerative changes are often evident on plain films, particularly with the advancing age, but these findings are not clinically significant in most situations. So with X-ray, really, it's not possible to predict that these changes could be present. For X-rays, the recommendations are this alone is not sufficient. It can be seen as a complementary investigation along with CT or MRI, depending on what the problem is. Upright X-rays provide useful functional information about axial loading and is generally used in deformity. The long films, flexion extension, essential to identify segmental motion, which is important in surgical management of spondylolisthesis. Lateral bending images have been shown to be helpful in the deformity correction surgery. And we know that if this is mobile segment or not. CT is not sensitive for soft tissue concern. We know this. It's useful in diagnosis of fractures, dislocations, spondylolisthesis, scoliosis, and stenosis, and tumors. In patients who have contraindication to MRI, CT with myelo may be used. Recommendation for CT, there is no relevant literature to support the use of CT with and without contrast in initial investigation of acute, uncomplicated lower back pain. There is no relevant literature to support the use of CT lumbar spine without and with IV contrast in evaluation of surgery or intervention candidates with persistent or progressive symptoms during our first 6 weeks of conservative management. So it's important to know that CT may not be your first choice here unless there are other factors involved. MRI in acute back pain, last 10 years, 1,500 studies, 5 meta-analyses, 15 systemic reviews, and 193 review articles. MRI, most sensitive and specific imaging modality for lower back pain. Because of higher sensitivity, it often detects asymptomatic disc herniation and protrusions. It remains the recommendation of choice in somebody with acute back pain. Subacute or chronic low back pain or radiculopathy who have failed 6 weeks of conservative treatment, then you could get an MRI. Physical examination, signs of nerve root irritation, obviously, then you get that. And patients who have got some other neurological deterioration or signs, then you can get an MRI early before embarking on anything else. Serum studies, ESR, CRP, and CBC could be done in selected group of patients where you're thinking of infection along with this, or where there's tenderness involved as well. It may aid in evaluating for inflammatory or infectious process. Vitamin D or B12 in selected group of patients, just like in our part of the world, it's very common. 96% of the people have low vitamin D and 20% have B12 problems. So we do this routinely. Obviously, you can do urine tests, LFTs, lipase, depending on if you're thinking of an extra spinal cause. Evaluating calcium alkaline phosphatase is useful for spinal malignancies. So in conclusion, well-performed history and physical examination can help triage further imaging and diagnostic. Positive SLR has worse patient-related outcome measure score. There's no relevant evidence for use of CT lumbar spine without an IV contrast and evaluation of surgery. MRI is most sensitive and specific imaging modality for lower back pain. Well, we continue to do various things. So I think World Spine 9 after a couple of years is going to be happening in Athens. So you all are most welcome and to join us over there and have good fun. At the same time, we have WFNS Spine Committee as well as World Spinal Column Society sessions again in May, live in person, and hope to see you, many of you over there. And thank you again. It was a pleasure talking to you.
Thanks a lot, Salman. I think we have one question from Dr. Dipanshi. How lifting weight causes back pain? What are the preventive measures while lifting weights? Nowadays, it's a serious issue for the people who lift weights in gym or during exercise.
Okay. In the majority of scenarios, back pain during or after lifting weight is caused by poor posture or poor lifting technique. Rounding of the back is a common problem, and this can put the hips at an awkward angle that places stress on the ligaments on our spine. And the good posture is very important. We have to take the weight near to our body and flex our knees and take it from the floor and with it near our body, move it upward. It's very important to do that.
Thank you. I have one question. You didn't mention about the back schools for prevention. Do you think it is still useful, or you were applying that in your department and did you stop it?
Yes, yes. I mentioned as an education, when I said education during the slides, it meant only educational booklets sometimes, and sometimes education giving during the sessions of the back school, but all of them were included in the word education, and it was not helpful to eliminate back pain or eliminate the first attack of back pain. The back schools were very popular in the past. It used to be. But when you look at the literature now, they're not so much popular, and the reviews show that. Education alone is not helpful. But in the back school, if exercises are shown, and you, as a patient, you continue doing the exercises with the education, the combination of them, it is useful. But only education, it doesn't mean anything. Exercise should accompany it to be successful.
Thank you very much. Just let me ask you one question about exercise. It's quite common that we tell patients that swimming, walking is good, and running not so much because of the impact. But you know, most of people do like running, do like doing, playing tennis, playing golf. So. Do you think do you have any, when patients ask you about that, so if they have back pain, can they do golf, tennis, running, or they should stop doing that? What's your suggestion to them? Thank you.
Mhm. You know, walking is the most safest one, walking. And if you are, for example, older age, after 50, then there is the risk of osteoporosis also. And if you do jogging or running, for example, it is also useful maybe for the bone density to go up, but when you are young, not after 50. But if you are after 50, there is a risk of the bone breaks, you know, the vertebra breaks and other bones can break. So walking is the safest one. But if the patient doesn't have any osteoporosis and if he runs and during the first session he doesn't have any pain and that night he doesn't have any pain, then he can continue running. It changes from one person to another. But walking is the safest and the reviews show that.
Thank you. There is a question to Salman from Dr. Hedvin Vazvi.
Yeah.
About about spinal injections, both for cervical and lumbar for treating back pain. How long should we wait until offering, and what that kind of treatment for the patients?
Thank you for that question. I think Nicola is going to answer that in detail once he talks about injections. But you know, obviously, what we do is we do all, as we said, we should not hurry things. There should be a conservative period. Conservative period starts with obviously posture, exercise, medicines if required, and if there are risk factors, then we investigate early. On the other hand, we wait and then we investigate. And if we find the problem is just mechanical coming from joints, then it is possible that we can inject as well if it's very severe and not getting away. But I think generally a minimum period for any kind of a problem with back pain is considered a trial of up to 6 weeks.
Okay, thank you very much. I have another question to you about what I feel is a kind of a paradox on what we do, because we all know that the indiscriminate use of imaging studies, particularly MRI, is creating an overload of referrals to neurosurgeons, to surgeons, let's say, for patients who don't need to see a surgeon and should not have done it. But then on the other side, what is a very common thing is that they go to a neuro or to an ortho spine surgeon, and the first thing that is done is asking for an MRI. So how do you see this?
I think, you know, that is a problem that depends on training. So unfortunately, majority ortho colleagues who join spine have done a fellowship after their training, and obviously their exposure to spine surgery is then of that fellowship, which is like up to 12 months or 18 months. And in those scenarios, those people do not have enough experience to make decision what is right and what is wrong in many cases. And even, for example, many people that we see are coming from outside the city and they cannot come back afterwards. So in those people, yes, fair enough. You know, if they can't come back, you can do investigations early. But generally speaking, I think it's important that we give them that conservative trial. I tell them, if you've had pain for 10 days, 15 days, you know, 95% of chances that you will get better without doing anything. So just go away, enjoy, relax, you know, posture, exercise, make sure you don't take stress, there's no constipation, cough, stuff like that. And if they're smoking, I tell them this is the worst thing that you can do for yourself, etc., etc. And, you know, we take it from there. So, but what has happened recently, people with fellowship for 3 months, 6 months, come back, become spine surgeons, and then without experience are doing that, and then it's a problem.
Thank you.
One question from Dr. Rahmat Salah is for Salman, asking if after conservative treatment and the patient is not responding, and some of them went through laminectomy and discectomy. So we are applying a transfemoral injection and sacroiliac injection. What is your opinion for that?
Yeah, in selected group of patients, I do give them transfemoral injection. And if the pathology lies in SI joint and the pain is coming anteriorly to the thigh up till the knee, then we know the problem is SI joint pathology. And if you have ruled that out, then obviously you need to treat SI joint. So it's possible that you could have a small disc prolapse, but that is not the cause of the pain, but actually SI joint is. On the other hand, like, stuff like piriformis syndrome, ischial pain, local pain, because nowadays many people stretch, do things, and they are cold, they're not warmed up, and they get avulsion of muscles, so they get pain in various areas. So that doesn't mean that every patient needs surgery. So for example, for every 100 patients that I see who come for surgery to me, majority of them are already cooked, they've had MRI, etc. Only 2 or 3 require surgery. So we know that the surgical requirement is very, very low. But yes, injections are a good armamentum. You need to have that with you. Nicola is going to talk about that in detail. Nicola, a lot of pressure on you now.
This question is for Yeşim. Actually, use of a lumbar brace for pain management. What is your opinion for that? When is it indicated?
Mhm. If you look at the reviews, lumbar belts were not shown to be helpful to eliminate the first attack. But if you are actually leaving attack after the attack for a short duration, you can use corsets while the patient is getting mobilized. Only for that period. Not so much, only for a short time, at most 3 weeks after the attack.
Yeah. Another thing I must stress that we are talking about the acute back pain. If we are talking it, then it's not necessary at the acute pain time. It's not necessary to make exercises. Am I right?
Yes.
But chronic back pain patients, we always recommend exercises.
That's
Chronic
true.
back pain should be completely differentiated from acute pain episodes.
Yes.
Yeah. I think
Mehmet, I agree. Just to comment that obviously, if you have acute back pain, then you will not exercise. But generally speaking, what we do is we send them for like stuff like TENS, ultrasound therapy, heat bath therapy, and massage and stuff like that. And once their pain settles down 48 hours, 72 hours, then we get them to exercise from then onwards.
Yeah, I think this is also an important thing, because when you look at the literature, everywhere it says that all these passive modalities don't work and should not be offered to patients. But in fact, patients get better, or at least help. It probably is like giving medication. It will not cure the patient, the pathology by itself, but probably all of these helps to also to cope with the pain and to keep moving and to keep working until the pain settles by itself, right?
Totally agree.
We can finish our session here and give the other session moderators. And I want to say hello to Ed Bezel. Unfortunately, your talk is 1 hour later. it may be my mistake, actually, because we have no summertime schedule. You are talking 1 hour later.
Ed, you can unmute yourself. Yeah.
Yeah,
Sorry.
I cannot talk 1 hour later. I don't know how I communicated with, but I understood that my talk was at 10 a.m. here.
Is it?
Mehmet, can we do Ed's talk now?
Yeah. Yeah. Okay.
I'm really sorry.
Who is the moderators now?
Nicolay and I think Kim, if I'm right. I don't know.
Nikolai is here.
Ruli. Is Ruli here?
I think I'm for tomorrow, Salman.
Okay,
I'm
sorry.
for Thursday.
Okay. No problem.
I think, yeah, Ruli is
Nikolai.
today.
Hi.
You can start with Ed Benzel.
I'm sorry to mess things up.
It's
But
fine.
I'm-
Ed,
I'm
don't worry about
almost
it.
certain I confirmed my time was 10.
No problem.
Okay.
Welcome.
Thank you.
We are very happy to have you here.
Okay.
Sandeep, you want to moderate this session, please?
Yeah, I can, sure.
So you need
Ed,
to
would you
invite
like
Ed,
to
who's already there.
Yeah. So,
Can you hear
I
my
don't-
voice?
Yes,
So
Seth, he
do-
can.
Okay.
Seth, are you there?
Should I go?
Yeah, you can start. You can share your screen.
Do I continue after Dr. Benzel?
I'm sorry?
Do I
Yes, Seth.
continue? Okay.
Yes.
Can you see my slides here?
You can
Yes.
see it good. Thank you.
Okay. Again, I apologize. My talk was initially termed managing mechanical back pain. I talked with Mehmet and said, I'd rather talk about chronic pain and when not to operate and how to manage patients with back pain. I'm going to leave the surgical aspects of this up to Dr. Meyer, who will evidently talk in an hour and 20 minutes. I'm going to talk about sorting out who should have surgery and who shouldn't. The literature as a source of information is anecdotal, is based on investigational device exemption studies with a tremendous amount of bias and significant market and academic pressures. So the literature is flawed. Mark Twain and some attributed to a couple of other people, including Benjamin Disraeli, for this statement. There are three kinds of lies: lies, damned lies, and statistics. There is a significant amount of mounting literature that discusses false findings and original findings that were demonstrated efficacy of a treatment are subsequently found to be flawed. This is because, in large part, researcher bias. If I'm a artificial disc surgeon and I'm going to randomize patients to artificial disc versus other or fusion, I am going to design a study. I am going to determine failure, etc. The patient, on the other hand, if they didn't get the disc, feels they've lost the lottery. If they get the disc or randomized to a disc, will feel they won the lottery. So the studies can be designed, and there's also significant selection bias. This is reflected very nicely by a fellow named Scott, who is a gynecologist, I believe, and published this well over a decade. Talked about having a promising idea, possible value, encouraging reports for a strategy, then widespread enthusiasm, strong media pressures, general introduction, and it becomes a standard of treatment. Then complications are seen, damaging studies are published. This becomes widely publicized, perhaps in the courtroom with lawsuits. It is then condemned, et cetera, et cetera. Underneath this curve is a huge amount of hurt individuals and money exchanged. So the truth wears off. So we must be very careful about looking at the literature and determining how we manage patients. Per capita healthcare spending in the United States shows that we spend in the United States 7,000, probably more than that now, US dollars per adult per year for healthcare. This is $2,000 more than in any other country, as exhibited here. A large part of the financial burden that we have in the United States from healthcare costs related to the mounting number of administrators, non-providers who are very costly to the consumer. This is a map of the United States showing the density of spine surgery, and the dark brown are high density areas and the light brown are low density areas, and the difference between them is tenfold. So why is it that somebody who lives here is 10 times less likely to have a spine operation than somebody who lives here? I was interviewed by the New York Times in 2003, and this is the name of the article. I talked to my consultants from the media at the Cleveland Clinic, and they said, no matter what they ask you, answer it with one of 3 sound bites. And these were my sound bites. We physicians tend to cave into market pressures. In other words, operate for money. Less than 50% of operations are appropriate, and I'm specifically talking about lumbar fusion operations. And the system for physician reimbursement is totally perverted. I got my point across. Why are we having so much problem identifying patients for back pain? For example, at the Cleveland Clinic, where I think we all are, all of the spine surgeons are fairly selective. When we look at our health-related quality of life metrics before and after surgery, we don't see a significant amount of improvement. In other words, we're not really helping patients. And I think we're helping some a lot and perhaps hurting others. I think the solution to this problem is the identification of a chronic pain patient. We don't see this patient. All we see is somebody complaining of back pain. There are many chronic pain syndromes: TMJ pain, headache, pelvic pain, GI pain, arthralgias, fibromyalgia, and of course, back pain. The healthcare budget or expenditure in the United States is roughly $2 trillion a year. A third of that is spent on chronic pain, about $635 billion. And if we could cut that only by half, we would move our healthcare expenditure down to this plane rather than up here. We spend nearly 20% of our the gross domestic product on healthcare in the United States, 17.4%, nearly 24% now. If we could eliminate that 15%, we could bring it down to where it was in the early 90s. So let's talk about back pain. I'm going to discuss 4 types: myofascial, inflammatory, mechanical, and chronic back pain. Myofascial back pain, I believe you were talking about it just before my talk, is episodic, affects all ages. It's acute in onset. It's associated with muscle tenderness. It usually improves with time and exercise, and it's extraordinarily common. I'm guessing most people on this call have had one or more episodes of myofascial back pain. Inflammatory back pain, such as ankylosing spondylitis, affects young adults, usually males. Early morning pain, gradual onset, improve with exercise, does not improve with rest. It can be nocturnal, perhaps particularly in the second half of the night, with morning stiffness and pain for greater than 3 months, and that can be associated with alternating buttocks pain. And the most common imaging finding is a sclerosis of the SI joint, or blood test at the HLBA blood test for ankylosing spondylitis. Mechanical back pain is the pain that we can affect with surgery. It is a syndrome. It is deep and agonizing pain that is worsened by loading and improved by unloading. If the patient cannot find a position of comfort, then how can we possibly put them and hold them in a position of comfort with an operation? So chronic back pain is chronic. It's greater than 3 to 6 months in duration. The patients have classically non-restorative sleep, low energy level, decreased activity. They suffer, and they often have multiple unrelated somatic complaints. They're often on opiates, and they complain of 24/7 pain. If a patient has pain in every position, lying, sitting, standing, walking, again, it's hard for us to manage that pain with a surgical procedure. I would like to introduce a term that I think I made up, but as is often the case, usually somebody has thought of it before, and that is pseudoconcordance. Pseudoconcordance is an apparent but erroneous relationship between an assumed cause, for example, imaging studies, and an effect, such as back pain. Let's start with a patient who is a young male who has early morning pain, gradual onset, improved with exercise. He has all the characteristics of an inflammatory back pain patient. And he's got, that nobody notices, sclerosis of the SI joint, but he also has an L4-5 spondylolisthesis. And so the surgeon may very well say, aha, back pain, spondylolisthesis, fuse this patient. Well, what he's done, if he does that, is not take care of the patient's pain and now create the image of this patient being a chronic pain patient or a failed back surgery patient, usually with multiple operations to follow, when if the appropriate diagnosis would have been made in the first place, and blood tests, HLA-B27, et cetera, may have set this person off on a completely different course, a course of success. So now let's talk about chronic back pain. So if the patient complains of chronic pain, non-restorative sleep, 24/7 pain, they've been on opiates for the last several months, low energy level, multiple unrelated somatic complaints, and has complains of a great deal of suffering, and in other words, an emotions involved with it, and they have this finding here, they again may have, this patient may also have an operation inappropriately because the clinical finding, the clinical diagnosis is chronic pain syndrome, not mechanical pain syndrome. So if the patient has mechanical pain, this operation that we might apply here might be effective. If they don't, it won't be effective. This is a fellow named Satchel Paige. He's one of the first baseball players in the United States to break the color barrier and play in the national, play in Major League Baseball. He was sort of a comedian, but he once said, it's not what you don't know that hurts you. It's what you know that just ain't so. So we can be so convinced that we are right that we get hurt by that because we're not right. We see so many patients who want the easy way out. They want surgery. They want toxic pills and surgery. They're overweight. They may be smokers. They don't exercise, etc. And very few are interested in lifestyle changes to improve their lot in life. And the onus is on us to help these patients get to the right place and do the right thing. So when assessing patients for surgery, stop, think. The elephants are everywhere. Look around, ask, is there an elephant in the room? Think clinical diagnosis, then ask, does the imaging correlate? Not, I see an imaging finding and they complain of back pain, let's just fix it. Sort out the types of back pain, and mechanical back pain is the only true pain that we can affect with a surgical procedure. So I ask these questions of the patient. Do you have low energy? Do you get restful sleep? Do you spend more than 12 hours a day resting or sleeping? Does your pain cause a great deal of suffering? And do you have pain in more than two or more parts of your body? And if the answer to 3 or 4 or 5 of these is true, they probably have a chronic pain syndrome. So we manage it with we can manage it with active versus passive strategies. Active means lose weight, exercise, stop smoking, get off of opiates. Passive strategies are like opiates or surgery. Doctor, heal me. I don't want to put forth effort. I want you to just do an operation and wave your magic wand. So foundational strategies include core strengthening exercises, flexibility exercises, smoking cessation, and weight loss. And I like to use this imagery of a tent pole in a windstorm. The best way to stabilize this tent pole, which may be weakened and correlative of the patient's spine, is to tighten the tent ropes. That means tighten the muscles that support the spine. But first, work on flexibility. Never bounce, but try to work on flexion and work on extension, flexibility exercises, and strengthening of the abdominal, rectus abdominis muscles by lifting one leg in the upper, lifting both legs, and then eventually working up to crunches. This is something that most able-bodied humans can achieve if they put their mind to it. And then same thing, lying face down on a carpeted floor, lift one leg up, the other leg, both legs, and maybe getting into the rocking chair or airplane position, and increase duration and intensity of these exercises. So surgery for mechanical back pain, the patient must have mechanical back pain and failed aggressive non-operative management. And I emphasize establishing a clinical diagnosis, deep and agonizing pain, worsened by loading, and perhaps most importantly, the patient can find and seek a position of relative comfort. This patient can get better with a stabilization procedure, which Dr. Meyer will discuss later. So the surgery itself should restore alignment and eliminate pathological motion. My opinion, surgery for mechanical back pain should be employed relatively infrequently. I think we should empower the patient to do the things that can make them better. In my country, we in some centers, we can have access to cognitive behavioral therapy. That's pain psychologists and knowledgeable physical therapists working together to help patients get out of the hole they're in. I always discuss with patients hurt versus harm. This pain hurts you, but it is not going to harm you. And you would be surprised how many patients are surprised by the fact that it's not potentially dangerous. Do more, not less. Try to not rest so much so that when nighttime comes, you're ready to go to sleep. Sometimes membrane stabilizers like gabapentin or Lyrica can be helpful, and wean from opiates. Be very cognizant and explain to the patients about the opiate-induced hyperalgesia, which actually makes the pain syndrome worse. And first, do no harm. Primum non nocere, the Hippocratic Oath. So identify the patient with the chronic pain syndrome versus back pain. Establish the diagnosis, the clinical diagnosis, then work to the imaging studies. If you do these things and you have good outcomes, when you go home at night, you will feel like clicking your heels. So please, we all need to focus on doing the right thing and focus on establishing the correct diagnosis. I thank you very much.
Thanks, Ed, for a fantastic talk, and particularly for your very wise words to the young neurosurgeons. I think normally we are having questions after the end of the session, but as you have to go, we will take the questions now. So there is one question that, do you advise patients who are obese for surgery?
Oh, do I do surgery on obese patients?
Yeah.
Yeah, okay. Only if it's urgent or emergent, because of two reasons. The complication rate is going to be greater with obesity, and oftentimes the patients, when they gain weight, gain a lot of weight in front of them, so they change the mechanics of low back pain, and oftentimes losing weight will reduce the back pain, and it may be the best treatment that they can do. In other words, this is an active therapy on the patient's part. They would do something for themselves, and perhaps this is an opportunity to really save the patient's life. If you force the patient into a weight reduction program and their blood sugars drop, they have less risk of other problems, medical problems, you may be saving their life just by emphasizing the importance of losing weight for overall treatment.
So do you ever advise bariatric surgery to any of these patients before they undergo spine surgery?
The what?
The bariatric surgery.
Yeah.
Do you advise it to any of these patients?
I will send patients for bariatric surgery, but it's a long, drawn-out process. But yes, of course. I mean, one of the things that I do when it's talking to a patient about weight loss, I say, can you get up and down the stairs right now? And they say, with difficulty. And I say, imagine this. Take a backpack and put 50 pounds of rocks in it. Do you think you could then walk up the stairs? And they'd say, I don't think so. I said, now let's play a game. Let's pretend we could immediately take 50 pounds off of you. Would that make a big difference? And they are forced into saying, yes, it would. Because obese patients are in a form of denial and thinking, well, I had back pain before I gained all this weight. That all may be true, but you're not helping your cause with this, with the carrying around the increased weight. In fact, it's a disability. I mean, if they can't get up the stairs because they're too heavy, that's a huge disability.
Okay, any more questions for Ed? So there's one question that, what do you mean by membrane stabilizers?
The class of drugs that we use for managing pain that include gabapentin and Lyrica, these are seizure medicines, basically. And seizure medicines stabilize membranes in the brain, but they also stabilize membranes at other areas and cause aberrant information that's being transmitted from the periphery to the brain to cause the patient to feel they have pain. And if we stop those messages, it can be helpful in some cases. Our pain psychologists and our chronic pain doctors will use them routinely in managing these patients.
Okay, there are no more questions. So thanks, Ed, for your great talk. And I think, Salman, you can take over and we can continue with the previous session.
Okay, thank you very much.
Thank you, Ed. Salman?
Yes.
Yeah, I think you are moderating this session. We'll continue with this current session later on.
Okay, so I think it's you next. So why don't you go ahead?
Okay.
And again, we thank Ed for a wonderful talk and for especially for young neurosurgeons to remember when not to operate.
So I thank everyone for joining us for the 4th episode of Pearls from OR. And so this is a surgical video session, and I'll be talking on the transtubular microdiscectomy, where there will be 2 talks of different techniques of endoscopic surgeries following my talk. So basically, I'll just skip these history talks because I realize that there is another talk about history of the minimally invasive surgery. So we'll come to that later, but I'll just mention about Casper's contribution. He was the first to design this tubular retractor. And before that, I was using Casper's technique of hemilaminectomy, and I was doing it by hemilaminectomy retractor. I used the technique for 10, 12 years of my career. And for last 13 years, I've been using a tubular retractor. So, I don't know why. So now I use this metric set developed by Medtronic. Typically, I use a 14 millimeter diameter tube for a disc surgery. The usual length of the tube used is 4 to 6 centimeters, depending upon the weight of the patient. Incision size is 14 millimeter, just same as the size of the tube. In obese patients requiring a tube longer than 6 centimeters, I normally use an 18 millimeter diameter tube because in a longer tube, the maneuverability in a 14 millimeter tube becomes difficult. So I use the 18 millimeter tube there. So as far as the technique goes, identify the level with a needle, and this is the most important thing. You don't want to operate on the wrong level. And sometimes with the lumbarized sacrum or a sacralized lumbar vertebra, it can be challenging, but you have to be careful. A 14 millimeter paramedian incision is made about 1.5 to 2 centimeters away from the midline. The smallest dilator is inserted and docked at the spinolaminar junction. Serial dilators are placed, and the depth of the tube is measured on the scale, and appropriate size tube is inserted. You can see in the first image, the smallest dilator is inserted at the level of the disc. This now you are putting in serial dilators, and finally the appropriate size tube is inserted. This is the first case, and so this was a lady with a typical L5S1 disc on the left side, partly in the foramen. So this is an incision. I think this is a setup in the OR. This is the cranial caudal. This is right. This is left. As the disc was on the left side, the tube is inserted. This is a midline, slightly pointing medially, and I'll skip this video because so this is a post-op incision in the patient. So the case 2 is a large extruded migrated disc in a 30-year-old female who had low backache radiating to the left lower limb. There were no neurological deficits. Her BMI was just ideal, about 22. And so this is a large extruded disc. It migrated slightly caudally. So this is after the insertion of the tube. You can, particularly in the early stages of your career, you should always do an AP just to see that you are not too lateral or too medial. Occasionally, you can just cross over to the opposite side if you tilt the tube too obliquely. So here the tube has been inserted. This is cranial, this is caudal. We are operating from the left side. This is the inferior lamina, inferior edge of the L5 lamina. This is the ligamentum flavum. So the lateral edge of the ligamentum flavum is excised. You should be careful not to damage the facet joints, otherwise you can lead to instability. So now the dura is exposed. I just exposed just up to the level of the lateral part of the nerve. And here the disc was present in the axilla between the dura and the nerve root. And you can see here, this is a large extruded disc here. So this was still contained, so there's a small cut is made in the annulus fibrosus, and the soft part of the disc is removed. You can see here that you should not be just happy by removing whatever you could in the initial go, because there still can be a lot of loose fragments, so you should look carefully for all the loose fragments. And now you see there's a large loose fragment still there. So there is always a debate how much disc to remove. I typically remove between 30 to 40% of the disc or all the loose material which comes out easily. And the closure is very easy. You just remove the tube, put a couple of stitches in the fascia, and then subcuticular stitches. So this is another case who had, see, some of these patients, particularly older patients, may have a lumbar canal stenosis also with hypertrophic ligamentum flavum. So along with the disc surgery, we tend to do decompression also. So he's a 56-year-old female with low backache radiated to both lower limbs. There was neurogenic claudication. She had no deficits on examination. Her BMI was 26. And as you can see in the MRI, there's a big central disc and there is hypertrophic ligaments bilaterally. So again, we are doing the same procedure. Usually for canal stenosis, I use the 18mm tube because you have to do a crossover, and sometimes I find it challenging with the 14mm tube. And dissect out the muscle. Now the difference in the bone work between a simple disc versus decompression would be that in the decompression, you have to do crossover decompression also to go to the opposite facet joint. So here we are nearing the opposite facet joint. And the cranial work is also more because you want to remove the ligament completely. And so you drill out the bone till you see the epidural fat coming out, because that would suggest that you are at the origin of the ligament. And now the whole ligament is exposed, and then you remove it piecemeal. I'll just forward it a bit. So now you can see that the whole ligament is detached and the dura is free. And then you gradually remove part of the facet joint to do a foraminotomy. This is the opposite side. And if it is not a disc prolapse, then generally you can do opposite side decompression better, because the visualization is much better here. In this, we are trying to expose the opposite nerve root. And now you see after the decompression, this is the opposite nerve root, which is quite free now. And you do the similar procedure on ipsilateral side, and then you are now proceeding to remove the disc. So it was a typical soft disc, which came out easily. So with that small incision, one can do decompression for the lumbar canal stenosis and the discectomy also. So this next patient is a 48-year-old male who was a morbidly obese guy. His BMI was 42.5. His weight was 145 kgs. He had undergone a bariatric surgery 2 years ago when he was more than 180 kgs. He had a right foot drop for last 3 years, and he was just too scared of surgery. Now he came for surgery because he developed left lower limb pain also for last 3 months, and he was worried that he may develop a foot drop on that side also. So you can see that there is a L4-5 disc. Actually, this is more on the right side here, and there's a large calcified L5-S1 disc. And this is a patient in the OR. You can see this, his tummy is hanging right up to here, nearly touching the floor. And so in this patient, I use a 8 centimeter long tube. The longest that we have is the 9 centimeter tube, which I had to use only once in my life. But 8 centimeters is also very unusual. And as the depth increases, the surgical difficulty keeps on increasing. So, and I use an 80mm diameter tube here. So this is the L5-S1 calcified disc, while this is the L4-5 disc. The L4-5 was a typical soft disc, which came out quite easily, while the L5-S1 disc was quite calcified, and there were chunks of calcified ligament which kept on coming out. This patient was a diabetic also, which I forgot to mention, and he was insisting for fusion, but I was not very keen on fusing such an obese guy with diabetes. So somehow I convinced him to undergo a minimally invasive procedure, and ultimately the outcome was quite good. So the advantages of a minimally invasive procedure would be decrease in the perioperative morbidity, lower operative times, reduce hospital stays, and reduction in the immediate postoperative pain, which has since recovery. And there is a shorter return to the work interval, the lower complication and reherniation rates, and the lower risk of developing instability as posterior elements are well preserved. Now, what are the complications that we can see in these procedures? The dural tear is the most commonly reported complication, and our incidence would be around 5%. There can be a CSF cutaneous fistula, which I have seen only in one patient ever. And sometimes pseudomeningocele can be there. That is again seen in very few patients. And most of the patients who have CSF leak, actually nothing happens and they heal pretty well. Again, if there is a pseudomeningocele, we keep them on Diamox for some time, and most of them disappear on their own. So disc-space infection again is a very rare complication, and the incidence is much lower as compared to an open laminectomy procedure. Again, postoperative lumbar epidural hematoma is a common thing, but symptomatic hematomas are very rare. There can be a nerve root injury. Again, this is a very rare complication. Some patients may develop a neurogenic bladder or urinary retention, and in most patients, it heals spontaneously. If you damage the facet joint, some patients run a risk of developing spinal instability in future, and a recurrence or a reherniation is a realistic possibility. That is actually the most common problem that you see, and our incidence has been between 2 to 3%. So I'll just show you a short video of a dural tear. So this patient had a partial dural tear. You can see the arachnoid popping out. Sometimes you can just leave it alone or just put some glue over it. Here it was in a pretty accessible location, so we just decided to suture it so that there is no postoperative CSF leak there. Sometimes it can be challenging to suture dura through a tube, but once you get used to it, you can do it actually pretty quickly. So this is what you actually don't want to see, which happens in very few patients. Though a lot of patients develop dural tears, there may be a small tear, but the nerve roots herniating out is an uncommon thing. But when they come out, then sometimes it becomes very challenging to put them back in. So ideally, you should put the patient in Trendelenburg position so that gravity will assist you, the CSF pressure will become less, and then you can reposition the nerves. And like here, we just push them back in. And if you find it difficult, you can enlarge the dural opening to just do that. And then you can do a complete dural closure. So like in this patient, a complete dural closure was done, and the patient did not have any postoperative issues. So there have been some articles relating the size of the discectomy and the annular defect with recurrence. So this was a paper, there are very few articles on that actually. So this was a paper from Johns Hopkins published in 2009. And they found that they compared the recurrent herniation with no recurrent herniation. And in patients where they had no recurrence, 28% of the disc was removed, while the patients who had a recurrent herniation, only 13% had been removed. Secondly, they compared the annular size defect. In the patients with herniation, the annular size defect was nearly 50% more than the patients without any recurrence. So the take-home message is that transtubular microdiscectomy is a simple and safe, minimally invasive technique. It doesn't require any special equipment, and learning curve is fast. Recovery of the patient is quick, and all are discharged within 24 hours of surgery. The same technique can be extended to decompress lumbar canal stenosis and excision of intradural tumors. Thank you. I would like to acknowledge my colleague, Dr. Utkarsh Bhagat, and who actually takes care of all the dural tears that I do, and Dr. Mukesh Bish, who helped me making this presentation. Thank you.
Thank you, Sandeep. Rudli, are you there?
Why can't I? So there's a small announcement. This is particularly for all the members. we are going to have a lucky draw tomorrow. And as you know that we came out with a textbook last year on minimally invasive surgery. So we are coming out with the second textbook, which is on spine deformity surgery. So all those people who will participate in this lucky draw, 2 people run a chance to win this book tomorrow. So we will run this draw tomorrow, and all those people who are members will only be eligible for this. And those who are not members till now, or they have not paid their dues should do that before midnight today to be eligible for this raffle.
Thank you, Sandeep. It was excellent talk. We will have the questions at the end. Imad, can you please unmute Ruli? He cannot unmute himself. Can you put him in as one of the speakers, please? Just move him up here, please. Imad, are you there?
Yeah, hello, Professor. How are you? Hello, friends.
Good to see you. I can't see you, so we better see you. I was going to say good to see you. Good to hear from you, actually.
I was in the middle of the driving, so I cannot start my video. Yeah, I'm sorry.
Can you introduce the Kim while driving?
Okay. Next speaker will be Dr. Hyun Sun Kim. So, Kim, are you there?
Yes. Next presenter is Joachim.
Joachim is not here. He's going to give both his talks tomorrow.
Okay.
Yeah. Kim will give.
Can I share my slide?
Yes, of course.
Okay. Can you see my slide?
You all, friends.
Okay. Thank you so much, Dr. Luli and Dr. Salman Sharif, and it is my great honor to give a talk in the first from the OR. This time my topic is lumbar disc surgery case with the video and the transfemoral endoscopy video presentation. Yes, we already well known that the endoscopic spine surgery already developed so much, and it have a first generation of transfemoral endoscopic lumbectomy and second generation of intralumbal endoscopic lumbectomy, and now going on the some endoscopic decompression generation and endoscopic fusion generation, and also now so many doctors doing very nice surgery for endoscopic lumbatory fusion. And also with the development of 2 ways of the endoscopic instrument, such as endoscope of small scope and large scope, and uniportal scope and biportal scope, and also development of the soft tissue manipulation system, such as ablation system. And the endoscopic technique developed so much, and near all problems of degenerative lumbar spine can solved by the endoscopically. Today, my topic is transfemoral endoscopic lumbectomy, and also we allow well known that the endoscopic transfemoral approach firstly applied from the Dr. Tony Young using the inside-out technique. But there is first trial of the visualized approach for intradiscal area. But this technique using the firstly docking the working channel into the discal area, some move to the target point like some highly superior migrated and highly inferior migrated disc is not easy because of that. To overcome this problem, outside-in approach from the Professor Dr. Thomas Hugland developed, and indication of transfemoral approach more wider. Outside-in approach usually firstly docking the working channel, not inside of the disc, outside around the foramen, then approach to the target point. Because of that, it is some difficult, more higher learning curve and some difficult for beginner. But After overcome and learning this technique, we can apply the more wide area indication of the lumbar disc herniation using the transfemoral approach. And that approach still have some problems, not easily approach for highly inferior migrated disc and high canal compromised cases and highly superior migrated cases. Because of that, it needs some more advanced technique. And nowadays, many expert endoscope surgeons using the mobile outside inoperative for the all types of the lumbar disc herniation, like this. Firstly, docking the working channel transforaminal area and then move to the target point of the working channel, then solve the pathologic problems. Now I will discuss the 4 cases of very difficult cases of the transfemoral approach. Because of that, some easy cases of paracentral and some mild migration cases can already talk so many times. And today I will show some more difficult cases. First case is some highly inferior migration cases. You can see it over the half of the pedicle. Because of that, before time, the near half of the pedicle inferior migrate cases is not is a contraindication of transfemoral approach, because there is not easy solve that problem with some obstacles of the bony structures like a pedicle and the facet joint. But with the development of the endoscopic drill, it can nowadays it can solve it very easily. This technique of suprapedicular circumferential opening technique published by me in Biomed Research, and you can see here there's some resection of the pedicle, partial resection of pedicle, and widening of the opening point of the to the target point. Then now you can see this here, pedicle here, here L5, here L4, and you can see here this cut area. It means that here is a truly epidural space that blocking the bone structures like this pedicle. Then because of that, we can resect this area and widening this area, then directly approach to the target point in spite of the like this highly inferior migration cases. After then you can see the some pulsating free nerve root here. There is a final point of the lumbar of highly inferior migrate cases. You can see here the final free oral space and not insert into the discal area. Then after operation, you can see the disc removed completely, and also the patient's problem solved completely. Second case is some highly inferior migration cases with recurred cases after open microdiscectomy, and also this case is also not easy before, and sometimes some contraindication because of that some adhesion tissue can blocking the approach to the target point. But this also can easily solved by development of the endoscope drill, like suprapedicular circumferential opening technique, because of that this area is a virgin area, not adherent area. Because of that, if we opening this area more sufficiently, this problem can solve more sufficiently. And also this technique published in Central European Neurosurgery by me. You can see here the similar approach to the previous technique. Firstly, docking the working channel to the pedicle area, and then drilling this pedicle area, and then remove the ruptured migrate disc, highly inferior migration disc. You can see here there's some pedicle, and now see the free after space area. And after operation, you can see all problems solved completely. And also, but in spite of the development of this surgical technique, sometimes some cases are like this highly superior, very, very highly superior migrated or very, very highly inferior migrated cases that blocked by the pedicle is not easy in the transforaminal approach. But unfortunately, Dr. Kuntran Chuk introduced the transpedicular approach. And it can like this, docking the working channel to the pedicle area and drilling this point and open this area. Then can possible approach the epidural space in spite of this like the very highly superior migrated or inferior migrated cases. You can see firstly docking the pedicle, alpha pedicle, then drilling this pedicle area. Firstly, can see the hard cortical area and then soft cancellous bone area, and after final can see the hard cortical area again. Then after drilling here, you can see the some epidural area, but here you can see the some blocking by the nerve root. Because of that, some drilling the more ventral parts of the water body and pedicle area. Then you can see the rupture disc here. Then easily solve remove this pathologic disc by the pedicular approach. After remove this huge rupture disc, in spite of like this highly superior and highly inferior portion, we can remove the safely by the transpedicular approach. And then you can, after operation, you can see the pedicle resection point and the disc removed completely. And also, Salman already mentioned that the question about some what the result of the impending neurologic state like this coda echina or some nerve damage status. And also before time, the like this situation, some coda echina and nerve damage state is very danger situation. Because of that, the transforaminal approach is a completely contraindication. They believe at that time they believe that there also can, if we not solve their problems completely, the nerve recovery will lack completely. But with the development of the surgical skill, we can remove this pathology completely. And also I published the result by Central European Neurosurgery. And the key point of that is some complete resection of this annulus. You can see here. Firstly, remove the intradiscal area, then resect the annulus completely, then decompress the nerve root completely. You can see here, still nerve root compressed because of that some resection of the epidural space. Resection of annulus, then you can see complete resection of annulus can take this result, and also the foot drop or coda echina can solve the completely. And this is final cases. Also, you can see here the this case is also published in Acta Neurochirurgia. And before time, like this case is ipsilateral cranial migrated, ipsilateral caudal migrated, and contralateral cranial migrated, and contralateral inferior migrated. It's a four corner is very difficult to approach. But I already mentioned that with using the mobile outside approach, we can approach all area of the intraspinal area. It is very important that because of that, if we solving this problem, it meaning that all intraspinal pathology can solve by endoscopically. This technique, like this, some mobile outside technique, then you can see firstly docking the transforaminal area, and the key point is that some widening the transforaminal area to easily mobile the working channel to the target point. Firstly, remove the ipsilateral inferior migrated disc, then move to the inferior superior migrated portion, then remove this point, then insert more deeper and some resection of annulus, then approach to the contralateral, and the contralateral superior and inferior migrated also can sufficiently and safely solve completely. And after then, you can see this problem solve completely. In conclusion, yes, we endoscopic spine surgery is still some progressing technology, but we endoscopic spine surgeon, and we try to take a successful surgery and safe surgery, and give some support for research and development. But in my paper published in Pain Vision, applied to the transfer endoscopic spine surgery for all types of lumbar disc herniation, then take more than 95% of good to excellent result. It means that after expert the endoscopic spine surgery, or lumbar pathology, especially lumbar disc herniation, can solved by endoscopically. And also keep in mind that the endoscopic by give the talking from the Tony Young, the basics and essential mind of the endoscopic spine surgery came from the transfemoral approach like these cases. Thank you for your kind attention.
Thank you, Kim. Excellent talk. Really enjoyed that. Sorry, we're running out of time, but I think we have a couple of questions. One was this transpedicular approach that you showed. So we are doing a minimally invasive procedure, but we are doing maximally invasive drilling, going through the pedicle to take out a disc. Do you think it's a good thing to do?
Yeah, actually, we think like that some pedicle resection is some aggressive process, but fortunately, after CT cutting image, the only some center of the pedicle some resection, not a margin of the pedicle safe completely. That means that the Guntram Chak also already mentioned that that point can remodeling. Don't worry.
Okay. There's a question by Dira Atman, and he's asking that what about hard disk? Can you drill the hard disk?
Hard disk, maybe.
Yeah. Calcified
we
disk.
know that some hard disk not give the symptom always. Some complete hard disk usually not give the some symptoms. Some incomplete calcified disk or some mobile calcified give the some have some symptom. Because of that, I already published my technique in some surroundings resection technique. I use the like that technique because of that. Some drilling the center, sometimes some give the damage with the during the drilling times of the some characteristics of mobile calcified point. Because of that, firstly, I will resect the nerve and protect the nerve completely, then drilling the around the area, then resect the calcified disc by one piece.
Okay. There's another question. What dye did you inject there, and did you inject in the migrated disc or into the disc itself?
What?
You know, the last case you showed, what dye did you inject? And did you inject into the migrated disc or into the disc itself?
No. Indigo carmine usually pigmented in spite of the dye inject to only intradiscal area. It some migration to the ruptured point pigmented. Because of that, not direct inject to the ruptured disc area, only intradiscal area.
Okay. There's another question that if you're doing a recurrent endoscopic surgery, how do you tackle post-op adhesions? Do you separate those adhesions first from dura and nerve and then proceed, or how do you go about it?
Yes, recurrent disc has some two different characteristics. One is some recurrent from the open microdiscectomy, and another recurrence is recurrence from the endoscopic transforaminal or intraminal discectomy. Usually, I think that maybe it maybe came from open microdiscectomy. Usually, open microdiscectomy, in spite of the open microdiscectomy, we can meet many times of severe adhesion, but usually development of the surgical skills of the open microdiscectomy and some materials of some anti-adhesive agent. Recently, I met many cases can resect very easily. Anyway, some resection of the adhesion point is very important in the recurrent disc open microdiscectomy. Firstly, I find the free epidural space like some already open surgery area or outside that area, we can find some free epidural space, then insert the forceps, then resect, then more safely dissect the adhesion point.
Okay, Kim, that was very good. Can you unshare your screen, please? And there's a question for Sandeep from Sudhir, and he's asking, in case of neurological deficits, when you take out the disc, how long does it take for the neurology to recover?
That would depend upon what kind of deficits you have produced. Sometimes in L1, L2 discs, you are retracting the nerves and it's very close to cauda equina. I've seen in few patients that they may develop some hip weakness, but usually it is transient and it recovers in 2-3 days. In lower lumbar discs, unless you really damage the nerve, I really don't see any deficits. But if it is just because of handling, I think I would expect it to improve in few days to few weeks at the most. But if you have damaged the nerve completely, then it may not improve then.
Okay, I think you're going to move on to the last session as we are running late. The last session moderators are Sandeep, Visha, and we're going to have Seth Nadiri. Both of them will be moderating this session. So guys, carry on.
Yeah, so Seth, your talk, Ed has already delivered his talk. So.
Good afternoon. Can you see my slide?
Yes.
Okay, I will start. As you know, minimally invasive spine surgery has been popular in recent 30 years. And during this talk, I will summarize the role of and history of MIS in disc surgery, in stenosis surgery, in pedicle instrumentation surgery, and in interbody fusion surgery. But first, I will talk on lumbar disc surgery. As you know, lumbar disc herniation as a concept was defined by Mixter and Barr in 1932. Actually, before them, many people, including Dandy and Krause, removed herniated disc, but they called it as enchondroma. But they presented the diagnosis, symptomatology, and the treatment of disc herniations. But what they did in their first case, they diagnosed using myelography, and it's very interesting that they did L2 to S1 laminectomy. This is very unbelievable for today. And they opened the dura and removed the disc through the dura. Actually, all the other surgeons used the same technique until 38. But in 38, Dr. Love from Mayo Clinic reported first keyhole laminectomy, laminectomy in one side, in one level, and removed the disc herniation extradurally, very similar to our today's technique. Yashargil and Kaspar were the pioneers of the microdiscectomy. The main difference between Ghazi Yaşargil and Kaspar was Kaspar removed the disc after medial facetectomy. This was the main difference. And in 1975, Hijikata started the era of percutaneous discectomy. He performed the first nucleotomy at this date, and in 83, Kambin used the orthopedic arthroscope for intradiscal decompression. But actually, what he did was blind intradiscal decompression. 5 years later, he defined Kambin triangle, which all endoscopic surgeons and also microsurgeons also use this triangle. In 1998, Dr. Anthony Young described first multi-channel endoscope with working channels. The main difference was you could use only one endoscope, and at the same time it had endoscope, irrigation channel, drainage channel, and a working channel for instruments. It actually facilitated endoscopic surgery by the use only one cannula in one side. And he reported first successful cases. Schubert and Hoogland reported foraminoplasty. Actually, Dr. Kim talked a little also. And Dr. Ganchoy in 2006 reported interlaminar and targeted fragmentectomy of extraforaminal herniations. Similarly, Dr. Rüttem from Germany in 2006 reported extreme lateral access, 12 or to 14 or 15 centimeter lateral to the midline, and interlaminar approach to disc herniations. Actually, today's most popular lumbar endoscopic discectomy approach are transforaminal, interlaminar, and extraforaminal for extraforaminal and foraminal disc herniations, interlaminar for commonly for L5-S1, and transforaminal for paramedian disc herniations. For this aim, there are many different endoscopic points and manual or electrical drills and different types of the endoscope with different diameters. On the other hand, as neurosurgeons were at that time were not familiar with endoscopic surgery, bipolar endoscopic discectomy was developed by Anthony in '96. In this technique, there was two incisions, two short incisions, one for endoscope and one for instrument. Actually, this technique allowed for discectomy and stenosis surgery, very similar to microsurgical technique. In the West also, on the other hand, Foley and Smith in '97 and '99 reported microendoscopic discectomy. In this technique, they used a tubular retractor and started to do endoscopic discectomy, and in the case of any difficulty, they could turn to microsurgical technique. And as you can see here, there were many different types of tubular retractor, which these retractors have been used for instrumentation for other aims later. So finally, 2 years ago, AO Spine organized one consensus meeting for nomenclature of endoscopic spine surgery, and they called discectomy as full endoscopic lumbar discectomy, transforaminal, interlaminar, and extraforaminal endoscopic this surgery. There is actually a similar story for stenosis also. As you know, Putti and Verbier defined lumbar spinal stenosis and the use of total laminectomy for this aim. Mekulo in 98 described the use of unilateral approach for bilateral decompression. He used this corridor and could do decompression bilaterally without any muscle retraction in the contralateral side. Actually, this technique has been used later by all endoscopic surgeons as well. For example, Dr. Gaab and Ortel created Easy Go system. They used a tube and started to do discectomy and stenosis surgery, very similar to microsurgical technique. The main difference was there was no muscle retraction. They proceeded the tube through the muscles, and the rate of muscle necrosis after surgery was much more less. On the other hand, Dr. Rutten in 2006 described interlaminar approach for stenosis surgery, and finally, Dr. Hume in 2013 described biportal endoscopic bilateral decompression using unilateral approach, which was very similar to our microsurgical techniques. So, minimal invasive surgery has been used in pedicle instrumentation and fusion as well. As you know, the first for the first time, pedicle was used for instrumentation by Boucher in 59, and Roy Camille in 63 described also the use of pedicle screw fixation, very similar to our current technique. However, for the first time, Magel in 82 used percutaneous pedicle screw fixation with external skeletal fixation. He put actually the screws percutaneously, but could not fixate in the deep tissues. Therefore, all the ends of the shunt screws were outside. Later, in 93, Dr. Lowe used the same technique, but he performed also percutaneous interbody fusion. Dr. Matthews and Dr. Powers used the same technique, but they could connect the screws inside, but very superficially under the skin using plates and rods. And finally, Dr. Foley used full percutaneous pedicle screw fixation. He placed the screw with the similar technique, but he used a device which they called sextant. This device, they used this device for insertion of the rod into the tulips of the pedicle. Actually, originally, sextant is an instrument using by astronomy professionals. Later, the second version of the sextant has been introduced by a company, and this second version could reduce spondylolisthesis. With the time, other companies introduced many different types of the pedicle screw fixation using tubular retractor or sleeve retractors, and they are in the market currently. And in 2000, Dr. Müller reported endoscopic pedicle screw placement using tubular retractor. There are some other instruments in the lumbar spine. One of them is interspinous device. As you know, Dr. Knowles in 1957 actually reported a steel plug between the spinous processes to hold the spine in the flexed posture. But it was not at that time so popular. In 1986, Zenekas from France introduced Wallis system. And with the time, another companies from Germany, from USA, introduced many different types of the interspinous device. But with the time, I think the popularity of the interspinous devices decreased. Another spine instrumentation technique in the lumbar spine is facet fixation, which originally was reported by Dr. King in 1944, but Mager in 1980s reported percutaneous technique. Minimal invasive spine surgery led to improvement in interbody fusion procedures also. As you know, there are many different anterior, lateral, and posterior techniques for interbody fusion. For example, Dr. Burns in 1933 reported first case of ALIF, and Dr. Matthew reported in 1905 reported first laparoscopic ALIF. And later in 2010, Dr. Kim reported first robot-assisted ALIF. Actually, they used Da Vinci robot in order to reach minimally invasive to the anterior aspect of the L5-S1. Then they did standard laparoscopic fusion from anterior. How about PLIF? Actually, Dr. Clavard, a neurosurgeon, in 1953 introduced first PLIF. It was actually at that time, as you know, after definition of the lumbar discectomy, there were many cases of recurrence. And in order to prevent the recurrence, some surgeons advised to do fusion. And he was the first surgeon who performed PLIF in such a case. In 2011, Dr. Kim performed the first mini PLIF surgery. On the other hand, as you know, many orthopedic surgeons were not familiar with intraspinal surgery. Therefore, they couldn't do PLIF properly. Therefore, Dr. Harms and Rollinger in 1982 described TLIF technique, in which the insertion is a little in the lateral to the midline, and there was no need or less need for retraction of the dura. In 2002, Dr. Foley described first MIS-TLIF, and in 2008, Zhu described endoscopic TLIF. And finally, in 2001, Dr. Pimenta and Dr. Özgür described first lateral interbody fusion, and they called actually as that at that time is as XLIF. So, in summary, evolution of MIS was performed step by step. Actually, I skipped some steps because of short time here. Many new techniques were successful and provided with the time extended indications. And some techniques, I think, for example, interspinous devices were used for short time and are relatively out of market for now. Thank you very much for your attention.
Thank you, Said, for an excellent talk. If there are any questions, we will take after the next talk. And so the next talk will be by Dr. Bernhard Meyer from Germany, who will be talking on the role of surgery for back pain.
Is he here?
Can you unshare your screen?
Okay, I try to unshare, but unshare, okay. Okay.
Sandeep, I don't see Dr. Meyer here.
He's not here?
He's there.
Oh,
there.
I just saw him. Okay. All right. Fair enough.
No, I'm here.
Sandeep, you want to introduce?
I'm just ahead of schedule, so I was on the phone.
Yeah.
I will start right away.
Yeah, so you can start sharing your screen.
Yeah. So, can you hear me well?
Yes.
Yes, perfect.
Okay, very good. So the topic you gave me, the role of surgery for, let's say, chronic low back pain, obviously in 20 minutes is a hard task. So I concentrate on a couple of things and trying to give you at least my opinion, which is backed up by the literature. As early as in 2009, it's already 12, 13 years ago, there were in the Annals of Internal Medicine, in the Journal Club Review, and that was by non-surgeons, clearly telling us that there is not a good evidence for any kind of surgery for low back pain, not even for radiculopathy or spinal stenosis. So things have changed until then, at least for radiculopathy and spinal stenosis with the sports trials, and everything else that came out is this level 1 evidence, and nobody came around. It was left was the role of surgery for chronic low back pain, which has been an eternal problem in the last 20 years, I'd say. Many things have been tried, and many things, or most things, have failed. One of the problems is that you don't know what the underlying diagnosis is. If you look at that table, which is taken from Deo and Weinstein in the New England Journal of Medicine already 20 years ago, when this was an upcoming problem, that people were trying to do surgery for chronic low back pain, they basically showed that only a very, very small percentage of people with low back pain are actually have actually an indication for surgery, because all the other things that you see are non-surgical candidates. So the major problem is that you will see in an abundance of patients with chronic low back pain, and only a very, very small minority does have a clear diagnosis. And among those, only very, very few will actually profit from any type of surgery. And if you have just back pain, the number one thing that is bothering you, if you think about any type of surgery, basically at that time it was fusion, you have a problem with localization. All the diagnostic tools that you could do have a very, very low specificity and sensitivity. So a lot of them, like the ones that you just see here, have a very high rate of false and positives and also false negatives. So this added up then basically to the problem that, if you look, I need to go back. If you consider fusion, which was at that time the surgical procedure that you were thinking about, if people had low back pain and you would have found or thought you had found the reason for that would be lumbar fusion instrumentation. And the more complex you do that, the more problematic it gets, because in addition to a very weak indication, you know from these very good trials, especially from Sweden, and the higher the complexity of your fusion procedure, the more likely you will have a complication. If you read the literature on this type of surgery, which is for lumbar degenerative scoliosis, which is basically the maximum end stage of people having low back pain, you have a guarantee for at least one complication, either during surgery or during the follow-up. So this is quite clear, and this is very well documented. So the problem is that not only your indication is weak, not only the prospective and your prognosis is not so good, you have high complication rates in addition to what you do, either during surgery or then later on, as you see, adjacent segment disease is a problem, at least in the lumbar spine, not so much in the cervical spine. So if you look at what you can achieve with that type of surgery, there are two, let's say, hallmark publications. One is from Jeremy Fairbanks, and the other is from Peter Fritzel. One saying basically that there is a benefit of surgery, and the other saying it's not. And the problem is that this is a very heterogeneous population with regard to indication in both trials, and the definition of conservative therapy is obviously something which is also of matter. If you do just unstructured non-surgical therapy, non-intensive, you will have different results than if you use structured cognitive behavioral therapy in an intensive way. So the comparator matters at that with that regard. And 10 years later, Dr. Andrade just summarized all the 20 years of randomized controlled trials for surgery of chronic non-specific low back pain. And what he found out is that there is a huge citation bias in that, and I will show you. First of all, it starts with a publication bias. If you look at this, what you are actually interested in is the indication for surgery. That means you look, no matter what technique you use, at the indication, and this is the primary endpoint of your trial. But these are the indication trials, the number of which is about that, and these are the technical trials. These basically are all industry sponsored. These are not industry sponsored because the industry is not interested in that, which makes it a difficult undertaking. That means there is a publication bias, and then there is a citation bias. You see that surgeons as authors will always cite the randomized controlled trials which favor surgery, as opposed to here, the randomized controlled trial, which is not favoring surgery, is in the majority cited by non-surgeons, and vice versa. So at the core of this problem lies also something which has not been overcome, and this is a publication by Anne Mannion, who is also very critical of all that. And the summary of that is that even after 11 years post-treatment, then looking at 3 very good RCTs, there's no advantage of any type of surgery over intensive cognitive behavioral therapy and exercise rehabilitation, something we don't like to hear. So to conclude that, at least in a prophylactic way, if you see 3 things where you could think about surgery, that is isthmic spondylolysis, degenerative spondylolysis plus minus spinal stenosis, and low back pain with unspecific degenerative changes, then for those 2, there exists a good level of evidence that surgery is beneficial. I show you an atypical example of a bilateral isthmic spondylolysis in an athlete, a gymnast, which is obviously a clear indication for that type of surgery, and the patient were with a likelihood of 95%, according to the results of the Swedish trials, profit from that type of surgery. So this is a very clear indication in a symptomatic patient. And obviously, most of them you will see at L5S1. Same is true, and most of them will be older, in their mid-50s, when they become symptomatic. You all know, if you have claudication, degenerative listhesis, the sports trial by Weinstein and others have shown that these results are better surgically than non-surgically. So this is actually the only clear indication for back pain or low back pain for fusion. Now, for the unspecific degenerative lumbar disease, as I told you before, none of the data that are available favors actually fusion in a significant way. So the thing is that you need to avoid surgery before you had a structured cognitive behavior and even probably afterwards. And then there was the quest for alternatives, that means non-fusion techniques or other things to reduce your complication rates. And I will allude on one of those, which has been very popular, say 15 to 20 years ago, that is total lumbar disc replacement. You all know that most of the studies out there have been industry sponsored. This is one from Scandinavia by Hellum, which is not industry sponsored and thus the best evidence available. And it shows in a nutshell that if you have patients who have low back pain, and you can reduce it to one level and do the best you can on your indication, then some of them, and a considerable part, will profit more from implanting a total disc replacement than from cognitive therapy. The problem is, this is only a very, very minor difference, which is clinically not significant. Plus, on the other hand, you have complications. In the series of these 120 patients, one lost a leg because an artery was nicked and couldn't be repaired, which is obviously for a low back pain problem in at that time, 38-year-old male, something which is significant. So the Scandinavian authorities did not reimburse total lumbar disc replacement, despite the fact that there was a minor advantage for it. In essence, actually, the idea of total lumbar, this can be taken from that publication too, and from Ziegler's publication, that the idea behind it to preserve motion at that segment and to have less stress on the adjacent segment works. If you implant disc replacement, you will have, if you look at the facets of the adjacent segment, the same incidence of adjacent level disease as in the natural state. So that means it reduces adjacent segment disease to the natural history. Plus, and in addition to that, however, in the index segment itself, it significantly increases the facet degeneration as the price for that. And if you wait long enough, because most of these people are actually younger, you will have a problem with that. So for the time being, this is also something which, at least in my peer groups, has dropped drastically. That means implantation of total disc replacement, as opposed to 15 years ago, has basically vanished, at least in where I live and where I work. So what is left? This is already my conclusion for the lumbar disc. Renaud told you it is equivalent to fusion in selected patients. It is insignificantly superior to a prolonged conservative care. Nature is not easy to copy. If you reduce ASD, then this comes at the price for increased index facet degeneration. So I think it has at least the potential for development in the future. It might come back. So my only indication at the moment is, if a very young professional athlete comes and needs to get back to his sport, then I will implant these, which happens once or twice a year. Now, two short things which or at least surgery. Like you can at least call it surgery. I was the senior author of a publication in which we tried intraosseous basic vertebral nerve ablation for the treatment of chronic low back pain. It was from the outset a very good study. It was prospectively randomized, double-blind, sham-controlled, multi-center study, and it's published at the European Spine Surgeon. The idea is that you have the basic vertebral nerve, which actually, if you have the corresponding modic changes, transmits the pain from as a nociceptor of the end plates. And if you have something where you could do a nerve ablation like that, that might be helpful in it. So this is just in an ideal MR, you see the BVN terminus in the mid of the vertebral body, and this is after the RF ablation. So that's the procedure before and after. I just walk you very, very quickly through 15 sites, 225 patients were treated 2-in-1 over sham. So patients had a sham operation, so they didn't know in which arm they were. So the highest standard of actually a randomized trial that you can have. And these are the inclusion criteria. I don't want to go to, you can read the publication. Basically, in the end, and I come to the conclusion, what you see here is per protocol, per predefined protocol, there's a significant advantage of change in the pain score in patients who had an ablation, but that is -20 on the VAS scale. But if you look at the sham patients who got nothing, they had just a nick on their facet with a Yamshidi. They also had a -15 decrease of their pain. And not only immediately post-op, this could also be seen in the group of patients which only had sham after 1 year. What does it tell you? It works, but part of it is not really somatic. Part of it must be also in another area. The question then, does that discourage you from using that? Is up to you. I'm undecided for the time being. So it is a safe procedure. Nevertheless, it's costly, and nevertheless, it has a high rate of non-somatic action in it. So the other thing, which is surgically something which could be looked into, is a form of spinal cord stimulation with a different stimulator. In this instance, a high-frequency spinal cord stimulator, which was developed for patients with either failed back or with people who have chronic low back pain. It is the same principle as you probably know for spinal cord stimulation, with low frequencies for radicular pain or other things. So there's been a prospective randomized trial which was positive, and we just looked at it from our perspective in a group of patients who had chronic low back pain, in which we, and I go through this very quickly, and the primary endpoint was a successful trial with a VAS reduction of more than 50% for at least 2 weeks after the procedure. Of the 40 patients, 34 had a positive trial, so the test electrode and then the stimulation was positive, and then they got their stimulator implanted, and there was a median pain reduction for back pain from 8.1 to 2.9, which is 64%, and leg pain also 55%. You can read that as very positive, but you can also read that as A, being short-term results, so you don't know how long that lasts, and B, a reduction from 8 to 3 it's almost too good to be true. So most probably there is also a non-somatic thing together with the somatic component of the treatment. So both things, the BVN ablation as well as the high frequency spinal cord stimulation in patients with chronic low back pain where you don't find actually a real problem, and they should be very, very reluctant to offer major surgery, seem to work at least, and it's an intermediate option for or after intensive cognitive behavioral therapy has failed, and you think about major procedures like surgery or non-fusion options in that. And that is actually all that I wanted to tell you from my side, where I see the role of surgery in chronic low back pain. Thank you.
Hey, thank you, Meyer, for your great talk. So are there any questions? Let me just see.
Is it a question on the chat?
Yeah, there is one question. What is your opinion on intraoperative sinovertebral or basivertebral nerve ablation for patients with severe back pain with radiculopathy and non-specific degenerative spinal disease? Example in case of disc herniation.
That's a very long question.
Yep, I agree.
Well, I told you what I think about BVN ablation when they have severe back pain. But whenever you see something like if they have a radiculopathy and they have a stenosis or be it foraminal or whatever, or they have a lumbar disc, I wouldn't do that. I would just go for the obvious and decompress the spinal canal. And BVN is, for me, if you want to do it, completely reserved to people who have chronic low back pain for other reasons, discogenic, which used to be called. And according to that hypothesis, or our hypothesis, is actually an end plate pain.
So Bernard, can I ask a question? Just so if a patient comes to you now who's got chronic pain for a long time and is just in misery and has just back pain and you don't see any particular cause, but you see just black disc, that's all. Would you offer surgery to him?
No. The older I get, the less likely it is I will offer surgery to him. And actually, to be honest, among us, I'm trying to avoid the patient. And I actually discourage them to come to me. So, see, the degenerative disease is the one that I really don't like about spine surgery. If you do tumors, infections, trauma, deformity, everybody likes you. And they have obviously severe problems. The ones that don't have a severe problem, whatever you're trying to help them, they hate you. So, and among those, chronic low back pain without a reason are the ones I really try to avoid. I sent them away to my department of psychosomatics, who do the behavioral cognitive therapy. Some of them, you can see that they say, okay, yes, that's good. But many of them will turn away from you. They're desperately seeking a surgical solution, and then, boom.
Okay. Any more questions? Seth, can we ask something about the history? So what did you invent?
About what?
Oh, sight.
Yeah.
It's a joke, Seth. It's okay.
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 Is Imad putting up the slide?
Ahmad, can you just bring up the slide for membership, please?
Well, so I welcome all of you to become members of the Spinal Column Society, for those who are not members as of now. So there are a lot of perks of becoming members. You'll get free access to the official journal, which is called Neurosurgery, and access to top spine surgeons mentorship, free webinars, free access to MIS ebooks, and now the upcoming deformity book, and then priority in getting observership with Spine Masters, and access to members only area like this course, and then discounts in Congress and workshops. So I would request all of you to become member as soon as possible. And those who become member today will be eligible to be part of the referral for the free ebook, for the free book tomorrow.
Brilliant. You want to wrap it up, Sandeep, please?
Yeah, so we had a great session today, and so hope to see all of you tomorrow at the same time. So I think we can have a group photo.
Sure.
So all of you turn your videos on.
Please switch on your videos so that we can have a group photograph. Bernard, you too, sorry. Switch on the videos, please. Ruli is finally, we can see Ruli. Navath, you want to say a few words? Just unmute yourself, say a few words before we close. Ahmed, would you like to say a few words, please, just to wrap up?
Yeah, it was a great meeting. Thank you. Thank you, all the speakers. I wish to meet all the participants tomorrow. Tomorrow, there are also very hot topics.
Thank you. We all can find this. All right, thank you.
Bye-bye. Good night.
See you tomorrow.
Bye, everybody. Goodbye.